Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. We'll be off for Memorial Day and return on June 1st with Season 6. This summer, we'll continue to talk about living with COVID and the shift from pandemic crisis to endemic virus. We'll also continue to follow breaking news around new variants, the future of reproductive health and the Supreme Court, and humanitarian crises in Ukraine and around the world. We'll look at other urgent public health issues, including racism, gun violence, mental health, climate change, and overdose. And of course, we'll continue to cover the need for investments in public health infrastructure and surveillance for future pandemic threats. As we wind down Season 5, we have a few thank yous. First, huge thanks to our interns, Crystal Allen, Hannah Bennett, Maisie Conrad, and Caroline Wang, who bring fresh ideas and much needed support for the podcast. We'd also like to thank you, our listeners, for sharing your ideas and questions and for downloading this podcast more than 7 million times. We appreciate all the great ideas and questions that come from our listeners. So keep writing to us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu. And thank you for being part of this podcast. In a bonus episode today, I speak with Dr. Eric Toner of the Center for Health Security about monkeypox. Dr. Toner is an expert in bioterrorism and has researched emerging infectious diseases for 20 years. We discuss what monkeypox is and where it came from, how it spreads, treatments and prevention, and why these outbreaks are important to know about, but not necessarily cause for alarm. Let's listen. Eric Toner, thank you so much for joining us back on Public Health on Call.
My pleasure. Thank you.
Today, we're going to talk about monkeypox. Tell us, what is monkeypox? What are the symptoms? Is it fatal? What do we need to know?
Well, first of all, monkeypox does not come from monkeys. It is called monkeypox because it was first isolated from a monkey in Africa. But the reservoir for it is in rodents, and specifically rodents in Central and West Africa. So we've been aware of monkeypox for decades. We are mostly interested in it because it is a cousin of smallpox. And the symptoms, although are somewhat less severe, are quite similar to smallpox. And so every time there was an outbreak of monkeypox in the last 20 years, there was always concern, well, is it monkeypox or is it smallpox? Because if it's smallpox, a single case of smallpox would set off all sorts of alarms because smallpox has been eradicated since the late 70s. So it is a related orthopox virus. It, in most cases, causes relatively mild illness, meaning most people don't end up in the hospital with it. There are two strains, two clades, one in the Congo Basin, which tends to be more severe, another one in West Africa, which is less severe. And that is the strain that seems to be causing the current outbreak, which is primarily located in Europe, although there have been now cases in the US and perhaps in Canada. It starts with a flu-like illness, fever, feeling bad, but also pronounced swelling of the lymph nodes, and that's different from smallpox. After several days, a rash appears, and the rash looks like chickenpox or smallpox, and that progresses over the course of a week or two. And then finally, the pox crust over and people recover. It is said that the West African strain, which is a strain that we're dealing with, has a 1% mortality rate, but that is data in people in Africa. In the cases that have occurred in the developed world, nearly all have been fairly mild, and severe illness and death from it is rare. It has a long incubation period, somewhere between 1 and 2 weeks, which is good because it gives us a lot of time to intercede if we know someone's had a contact with the case. And we have both vaccines and antiviral treatments that are effective. And so like we would do with smallpox and did do with smallpox to eradicate it, ring vaccination works, meaning that if you see a case and you vaccinate the people around that case, you can stop the spread of the disease. And unlike many other diseases, you can vaccinate somebody after they've actually been exposed, and it will stop or at least lessen the severity of the disease. So there's little doubt that we can contain and stop this outbreak. It's not of great concern for the general public, although certainly it's of concern to people in public health and frontline healthcare workers.
How does it spread?
It spreads through large respiratory droplets and bodily fluids. So mostly it spreads through close or intimate contact with other people. It's not highly contagious, nothing like COVID, for example. Within a household, less than 10% of household contacts get infected. So, it's not that contagious, but it certainly is a concern for healthcare workers or close family members.
When you say large respiratory droplets, is this where, as opposed to COVID, which we know is aerosolized and you can breathe it in, is that a difference here?
Yeah. So what we're talking about is, if someone were to cough in your face or spit on you or, drool on you, probably also kissing. But, it is those kinds of contacts rather than being in a room with somebody, as can be the case with COVID. But it does also persist. So it does persist on clothing and on bed linens, for example.
Why is this in the news so much right now?
Well, there's the largest outbreak that we've seen outside of Africa in recent history. So this all started just a few days ago with a family in London where several members of the family got infected after one family member traveled from Nigeria, and monkeypox is endemic in Nigeria. But then cases started popping up in many other locations, a number of other cases in the UK, but also cases in Portugal, Spain, now Sweden, one case in the US, many suspected cases in Canada, and many more suspected cases elsewhere in Europe that are being investigated. So, it's unusually large outbreak for monkeypox. Only one of these people had a travel history to an endemic area. So the presumption is that everybody else is being infected through some sort of community transmission.
Is this something that is more dangerous for people that are immunocompromised or maybe older, or maybe this is more dangerous for children? Are there certain groups that are more at risk?
In Africa, most cases have been in children, but that may be because older people had been previously vaccinated for smallpox. No one's been vaccinated for smallpox for decades now. So older people might have had lingering immunity from smallpox vaccination. And young children were likely to be playing with rodents than adults. So we don't know if it's something that is inherent to the pathogen or whether it is prior vaccination or behavior.
When you're talking about the symptoms, you said there's flu-like symptoms and then there's like a pox. Is it painful? Is it itchy?
It is quite painful, typically, not excruciatingly painful. And there's a broad spectrum of illness. I mean, some people have only one or two pox, and others are covered in pox. And obviously those people who have it everywhere are miserable, and those people who have just a few don't feel that bad at all.
And what are public health experts like you watching right now? What are you looking for?
We're trying to understand the transmission of this, most importantly right now. Of the cases that are now known, the majority of them are men who've had sex with men. And so there is a question of whether or not this is being transmitted sexually, which has never been known before, or it could simply be close contact within a network. It could also be that because monkeypox can look initially like the rash from syphilis, that people who are particularly attuned to and watching for signs of syphilis would seek medical attention sooner than other people. So we don't yet know what's going on, but it has certainly spread farther than we would have expected or have seen in the past. And so we're trying very hard to understand the extent of it. Are we seeing most of the actual cases, or were we seeing the tip of the iceberg? We don't really know that yet. And then the question is this unprecedented outbreak because of change in the virus, or is it because of a change in behavior, or is it because of better surveillance and we're just finding cases that we would previously have missed?
So you had mentioned that the smallpox vaccination is helpful in this particular instance. So 2 questions for you there. The first one is, if the virus has changed, is that still the case? And the second is, are we going to bring back widespread vaccination against smallpox?
Well, in answer to your first question, there's no way to know at this point. This does tend to be a very stable virus. And so we haven't seen lots of mutations, unlike COVID or flu that's mutating constantly. The orthopox viruses tend to be quite stable. So I think the expectation is the vaccines would still be quite effective. It is very unlikely that we would do widespread vaccination. Even during the smallpox eradication program in the 60s and 70s, we rarely did mass vaccination. What we did was ring vaccination. That is, we vaccinated those people who had direct contact with a known case. And that's how smallpox was eradicated from the world. So that's happening now in the UK. They are vaccinating people who've been in contact with known cases. And it's certainly possible that we could do that in the United States and in other countries.
Is this a one-time vaccination, or are there possibilities of boosters being needed?
So there are 3 vaccines that are available. There's one vaccine that's actually licensed for monkeypox as well as smallpox. That vaccine is a 2-shot vaccine, 1 shot initially and then another shot 4 weeks later. The other vaccines are one-time vaccinations.
Is there anything else people should be aware of?
No, I think people in general don't really need to be that aware of this at all. I think this is not a threat to the general public. Certainly people who are practicing public health, local and state health departments, certainly need to be aware of it. I'm sure they are aware of it and on the lookout for it. And frontline healthcare workers should be aware of it and should be taking travel histories. And someone presenting with fever and rash, ought to be asked a few more questions. This is something that we drilled in people's heads 20 years ago when we were concerned about smallpox. And the same thing with Ebola. If someone has fever and rash, you need to ask them some more questions. So I think for the general public, this is not a concern.
Eric Toner, thank you so much for joining us today.
My pleasure. Thank you.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McClusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.